In 1871, Dr. Jacob da Costa evaluated Civil War veterans suffering a physical deterioration called irritable heart, documenting organic pathology like a rapid, elevated pulse. By World War I, physicians like Mackenzie and Rudolph observed the exact same pathology in a new generation of soldiers. They documented exhausted nervous systems and intensely unstable circulation, forcing military members into extended hospital convalescence. Over a century later, modern military medicine is battling the exact same systemic physical decline. Trauma survivors routinely present with severe cardiac and respiratory failures that outpace their chronological age. Current epidemiological data reveals that approximately 40% of individuals diagnosed with PTSD also suffer from the onset of metabolic syndrome. This is a dangerous clustering of obesity, hypertension, and lipid abnormalities, which is double the rate found in individuals without PTSD. This massive spike in cardiometabolic disease persists even when researchers control for the behavioral choices or lifestyle factors often associated with psychiatric illness. The cardiovascular deterioration seen in severe trauma survivors is the macroscopic manifestation of premature biological aging occurring at the cellular level. A patient's chronological age often masks their true biological age. In trauma survivors, the internal biological clock moves at a completely different, volatile speed. This accelerated cellular aging is a discrete pathological process. Extreme stress physically drives the cells to degrade and senesce far faster than the normal biological decay associated with time. To locate the exact mechanism of this decay, we have to peel back the layers of the organism, moving from the organ systems down to the genome itself. We trace this damage backward, starting with cardiometabolic disease, through the blood's immune system, down to the epigenetic algorithms that dictate our cellular lifespan. If clinicians want to intercept cardiovascular failure in trauma patients, they must first learn how to accurately measure the invisible pace of their biological clock. Before calculating how fast a trauma survivor's clock is ticking, we must account for the baseline genetic architecture they were born with. This diagram illustrates the direct shared genetic risk between PTSD and coronary artery disease. Nestled within that intersection are specific overlapping gene networks, heavily featuring the TNF-alpha gene and the NF-kappa B complex. These targets are the primary regulators of systemic inflammation and immune response. Researchers have also found that polygenic risk for obesity acts as a biological amplifier in these patients. It directly worsens metabolic syndrome severity and contributes to reduced cortical thickness in the brains of individuals with PTSD. Psychological trauma aggressively exploits and amplifies pre-existing genetic vulnerabilities in the body's inflammatory network. To measure the actual pace of this cellular decline, the psychiatric community spent years relying on the length of telomeres, the protective caps on the ends of chromosomes. This scatter plot charts leukocyte telomere length against chronological age, demonstrating the severe methodological variability that makes telomeres highly imprecise. Statistically, telomeres show a weak correlation with chronological age, hovering around an R-value of roughly 0.30. Biologically, shortened telomeres are better classified as markers of terminal cellular senescence, the point where a cell can no longer divide, rather than a metric for the ongoing pace of aging itself. The modern replacement is DNA methylation, widely known as the epigenetic clock. In stark contrast to telomeres, DNA methylation plots show an almost flawless correlation with chronological age across multiple tissue types, locking in at an R-value of 0.96. Abandoning telomeres in favor of DNA methylation clocks finally provides researchers with the mathematical precision needed to model the trauma aging hypothesis. Within DNA methylation research, two highly correlated algorithms dominate the field: the Horvath clock and the Hannum clock. They use different sampling methodologies. The Horvath algorithm evaluates 353 distinct loci across dozens of different body tissues. The Hannum algorithm is narrower, analyzing exactly 71 probes strictly within whole blood. This meta-analysis of over 2,000 subjects reveals a biological paradox. When tracking PTSD severity, researchers consistently observe positive residuals, indicating accelerated biological age, strictly on the Hannum index. Conversely, the multi-tissue Horvath index yields largely non-significant results for the exact same cohorts. This discrepancy occurs because the Hannum clock is developed entirely in blood. It is hypersensitive to circulating immunological factors that the broad, multi-tissue Horvath clock naturally mutes out. The Hannum algorithm's sensitivity to PTSD cohorts provides evidence that this biological acceleration is primarily linked to circulating immunological factors within the blood. Deep within the patient's bloodstream, a massive systemic cellular shift occurs in the direct aftermath of extreme psychological stress. Clinicians track this decline through a condition called immunosenescence, which is measured by calculating the ratio of CD4 to CD8 T cells in the blood. Severe trauma forcefully alters this ratio. It depletes the body's supply of naive T cells and overpopulates the bloodstream with late-stage, highly differentiated memory T cells. This imbalance triggers inflammatory aging. The toxic senescent T cells constantly release pro-inflammatory inflammatorines into the circulatory system. Acting like sandpaper over decades, this chronic inflammation physically damages the blood vessel walls, degrading endothelial integrity and prompting the early onset of cardiovascular disease. This flowchart models the complete sequence, demonstrating how these abstract biological layers lock together into a single cohesive pathology. The process begins with traumatic stress acting upon pre-existing genetic risk as the primary catalyst. This catalyst translates biologically, directly feeding into accelerated epigenetic aging and immunosenescence within the bloodstream. The resulting inflammation breaks down the endothelium, driving the clinical outputs of premature cardiometabolic disease and neurocognitive decline. This unified model frames PTSD as a multi-system aging disorder, requiring clinical management that reaches far beyond traditional neuropsychiatric boundaries. Knowing exactly how trauma accelerates the biological clock opens a clinical horizon to a new question: can targeted pharmacology slow it down? The massive inflammation generated by immunosenescence also drives oxidative stress, which systematically attacks and degrades the blood-brain barrier. Researchers are developing novel pharmacological targets to intervene and reinforce these barriers, such as the antioxidant SS31, which actively protects neurons from oxidative damage. Additional frontiers include testing adenosine receptor A2A antagonists, which have shown the ability to reverse blood-brain barrier permeability in laboratory models. Alongside pharmacology, clinical trials are actively evaluating behavioral interventions like strict diet and exercise, or even successful psychotherapy, can serve as functional epigenetic modifiers. Decoding the epigenetics of the soldier's heart provides a path toward therapies that mitigate cellular damage, potentially recovering biological time for trauma survivors.